Good afternoon, everybody. After an interesting discussion by the anesthesia department, now you have neurosurgery department over here. And we will be discussing some of the interesting cases that we have treated with radiosurgery. They're not very common if I have to compare it with the common medical conditions that we encounter. However, they are very, very troubling. And even for a single patient, I think if we do good and the results are fairly well, the patient definitely goes satisfied. It's worthwhile to discuss. The Department of Neurosurgery got ICON, that's a new gamma knife model, an upgrade over the perfection in the year October 22. And since that time, and the source was also renewed, our turnover of gamma knife radiosurgery cases definitely increased, and we could also increase the spectrum of patients that we could treat with ICON system. Gradually, with the index case, we take you through the steps of what we do in gamma knife radiosurgery. So may I now welcome our resident from the department, Dr. Shiva, to continue with the presentation. Thank you.
Good afternoon, everyone. Let me take you all on a journey of how we tamed the giants with radiosurgery, the saga of a bloodless war, the masked man. I am Dr. R. Sivakrishna, Junior Resident from the Department of Neurosurgery, and this is a tale about teamwork and how our allies managed to win over the giant. The story begins 15 years ago. Our patient had complaints of acromegalic features, that is, coarseness, facies, acral enlargement, change in voice. He had history of bilateral diminution of vision for the past 1 year, with vision in the right eye, acuity being 6/12, and left eye is almost blind with 2/60, with bitemporal field cuts on examination. His growth hormone and IGF-1 values were elevated, and the patient was diagnosed as a case of giant growth hormone secreting functional pituitary macroadenoma. The decision was taken to operate, and the patient underwent endoscopic TNTS in August 2022. Intraoperatively, a part of the tumor was very difficult to access as it was lateral to the ICA, and the principle of safe maximal resection was used, and a small residual was left over behind. In the post-op 3-month follow-up, the left eye visual acuity improved to 6/24, and there was significant drop in the growth hormone and IGF-1 values, but they still didn't return to the baseline. The MRI of November 2022 shows a 9.7 cc residual. I now invite Dr. Surojit from Department of Neuroradiology to take us through the imaging.
Good afternoon, everybody. Now, I'll be continuing with the imaging characteristics of the lesion. So, these are the representative T-on-weighted post-contrast images in different orthogonal planes and the corresponding video on corner plane. So, we can see a very well-defined lobulated masked lesion, which is appearing homogeneously enhancing on contrast scan, epicentered in sellar and suprasellar region. So the pituitary gland is not seen separately from the lesion, suggesting the origin of the lesion from the pituitary gland itself. Now coming to the extent of the lesion, we can see the superiorly the lesion is extending up to the floor of the third ventricle and displacing the optic chiasma here. Further, on slightly lateral side, we can see it is abutting the left gangliocapsular region. On laterally, on either side, the lesion is extending into bilateral cavernous sinus more on the left side as compared to the on the right side. On the left side, we can see the lesion is completely encasing the left cavernous ICA flow void. So the Knoss grading of cavernous sinus infiltration on the left side would be 4, and on the right side, we can see the lesion is partially abutting the right ICA flow void. The angular contact here being less than 180 degree. So the Knoss grading on this side would be 2. Now coming to the posterior aspect of the lesion, we can see the lesion is reaching up to the prepontine region and perimesencephalic cistern region. In the axial scan, we can see lesion is causing mass effect on the right side of the pons, right side of the midbrain, sorry. Inferiorly, we can see the lesion is causing significant compression and bulge over the sphenoid sinus region. So preoperatively, the volumetric analysis showed the lesion volume to be approximately 62.5 cc. So the patient underwent surgery. Then after 3 months, we had another MRI. We can see in this MRI there was a residual lesion on the left cavernous sinus and lateral to the left cavernous sinus region. Small amount of residual is also seen here in the suprasellar region, and the lesion is closely abutting the left cavernous ICA and lying in close proximity to the left orbital apex region. Thereby, it is also abutting the left prechiasmatic segment of the left optic nerve. So, postoperatively, the lesion volumetric analysis showed volume of 9.7 cc. So, on view of persistently raised hormonal profile, patient underwent another MRI 7 months afterwards. So, in this MRI, we can see the residual lesion the same location as described previously. However, in this scan, volumetric analysis showed a subtle increase in the lesion's volume, which was approximately 10.98 cc. So now I will invite Dr. Sachin to walk us through the endocrinological aspect of the lesion.
Good afternoon, respected faculty and dear colleagues. I would like to present the endocrine part of management of such a residual tumor. Whenever a patient who comes to us with such a residual tumor, we first like look at whether the patient has a clinically relevant tumor remnant or. So, a clinically relevant tumor remnant means any tumor remnant which is causing an optic chiasm or cranial nerve compression. So, if the patient has such a clinically relevant tumor remnant, or if the patient's tumor is functional, then we go ahead with referring the patient to neurosurgery for either a gamma knife or a definitive surgery. If the patient does not have such a clinically relevant tumor, then we usually follow up the patient with the repeat MRIs, and if it is showing a progressive disease as per RECIST criteria, then we refer to neurosurgery for further definitive management. In between the definitive management and the patient having functionality, usually we have a medical line of treatment as a bridge therapy. In this index case, he had a functional tumor with an IGF-1 more than 2 times upper limit of normal, and GH levels persistently elevated at 7.46 nanogram per ml. But the tumor volume was significant, and as already described, he had a visual defect as well in the post-op. So he had a clinically relevant tumor remnant. So we referred to neurosurgery, and in between, we start the patient on medical management. So what are the available medical management for patients with acromegaly? We basically have 3 drugs which are already approved for this management. One is the injectable long-acting somatostatin analog, which is the one which has the highest efficacy among the drugs which are available in India. The octreotide LAR, which is given monthly as a deep IM injection, 20 to 30 mg, has an efficacy of 30 to 40% normalization in several studies. However, it is expensive and costs around 20 to 30,000 per month, depending on the brand. The next drug which is available is cabergoline, which is a D2 receptor agonist. It is ease of application, as in it can be given orally, but it has a very poor efficacy of around 14%. Side effects include impulse control disorder and GI symptoms. Pegvisomant is a comparatively newer drug, but then it has to be given daily subcutaneously, and it is not available in India as of now. It can be given at 10 to 40 mg subcutaneously daily, and among those options which we have, it has the highest efficacy, 74% efficacy. Side effects include transaminitis and injection site reactions. So coming to guidelines of management of acromegaly, there is a recent trend of shift in the guidelines from a generalized flow to a more personalized approach in management of acromegaly. The most recent 2021 guidelines from Pituitary Society also highlights the same. So in any patient, the first choice obviously remains a surgery or debulking surgery. Once the patient has a persistent disease after this surgery, we go ahead with the medical therapy if there is a functional tumor. So we looked at factors which predict the somatostatin receptor response, which included densely granulated tumor, SSTR2 positive in IHC, low Ki67 in IHC, or if the MRI is showing T2 hypointensity. If all these features are there in the patient, then the first line of treatment becomes the first generation somatostatin receptor agonist. So if these factors predictive of resistance are present, then we can go ahead with either treatment with peglispamide or paclitaxel. And if the patient does not respond to the same, then we go ahead with combination of multiple agents. In the guidelines, including the Endocrine Society 2014 guidelines, the AAC 2011, as well as the latest Pituitary Society guidelines, in all of these, the stereotactic radiosurgery or radiotherapy is mentioned as the third line when both medical as well as surgical line of management fails. However, the same cannot be applied in our setting because we have a lot of other problems. First of all, the other drugs which they mention in patients with octreotide resistance, including peglispamide and paclitaxel, are not yet available in India. And cabergoline can be tried, and it is cheap, as was tried in this patient. However, its efficacy is poor, with studies showing only around 10 to 15% reduction, and it is only helpful in mild cases of acromegaly. Octreotide, among the drugs available, has a good efficacy with 30 to 40%, but it is very expensive, as in our patient also, the patient could not afford octreotide because it costs around 30,000 per injection, which has to be given once in 3 to 4 weeks. And these need to be continued lifelong for its efficacy to remain. So that is why we do not routinely put all the patients on it, and usually only put it as a bridge therapy and only in those patients who can afford it. Stereotactic radiosurgery will take time to act. It takes around 5 to 6 years for it to cure the functionality of the tumor and for tumor reduction, but then it is a one-time measure, so it is much more affordable and convenient in our patients. Like to call on Dr. Shivakrishna for further.
Thank you, Dr. Sachin. Now, what do we do in this patient? We have a residual of 11 cc, very close to the chiasm, and the growth hormones and IGF-1's values have been increasing. The medical management is not seeming to work. So we need to decide between a redo surgery and gamma. The factors going against a redo surgery are most of the tumor is in the form of a plaque, which is lateral to the IC. It is very difficult to access, and total resection without creating deficits is very unlikely. And even in gamma knife, we have to keep one thing in mind. The distance between the optic chiasm and the tumor is very small, is less than 0.3 mm. So this is how we started our bloodless war. Our target was a volume of 11 cc marked on our icon system. We used a frameless with a thermoplastic mask-based fixation in this patient. We decided to fractionate the dose because here we can see in yellow we have the 60% isodense line. The dose delivery at this line is 24 gray, and in green we can see a 12 gray isodose line, and the optic chiasm lies in between them. The tolerance for optic chiasm is only 10 gray. We can protect the optic chiasm with shielding and further increase this by dividing it into fractions. So we divided 24 grays in 5 fractions, and with our treatment protocol, about 95% coverage of the tumor was achieved with a prescription dose of 24 gray radiation. And the optic chiasm, in 5 fraction, the tolerance dose of optic chiasm increases from 10 to about 25. So less than 0.1% of the tumor receives more than 21.5. So we managed to achieve both our goals. Let me take you through the frameless patient flow. We get an imaging done, MRI under gamma knife protocol. Then we use a thermoplastic mask-based system to immobilize. Now this is more comfortable than a traditional frame-based fixation. In traditional frame-based fixation, you will have to give a local anesthetic and fix with rods and screws. And for 5 days continuously, it's a big burden for the patient. Then after a frame-based fixation, a cone beam CT scan is taken for stereotactic reference. We can use the MRI and the CT to get to merge those two scans and get a stereotactic reference frame in which we can plan our dose. Now, once a dose is planned, it is sent to the treatment console, and the patient with the fixation is there on the treatment console. Then another cone beam CT is placed to confirm the fiducials of the patient, and then a dose evaluation, because one thing to understand is in a frame-based fixation, it is a very rigid kind of fixation. In a mass-based fixation, there is always a possibility for movement. And when we are dealing with distances like 0.3 mm, even a very slight movement can make a lot of difference. So here we use technology where a motion sensing camera is used to detect the position of the patient and adjust for the radiation. And then we give the treatment. So how do we make the mask? This is the thermoplastic polymer that we get, which is moldable by exposure to high temperatures. So we use a 70-degree water bath exposure for 15 minutes to make it completely pliable. This is a styrofoam pouch that we get in an airtight packet, and it hardens on contact with surface and contact with air. So we place the cushion, and this molds its shape to the shape of the back of the patient's scalp to achieve a rigid fixation from the back. Then the thermoplastic mask is molded over the patient's face. We need to make sure to tap it down and to adjust the contours over the orbital prominences, over the cheek, over these bony prominences to get a good fixation with it. This is the adapter and the clipping frame which is used to achieve the fixation with mask. This is our entire system. Here you can notice a HDMI motion detector is used, and this is a camera which senses the motion of the patient. Even a slight head movement will trigger the motion sensing camera. It will adjust for the radiation to a certain threshold, and if there is excess motion, it will immediately stop the dose delivery. So the dose that you plan is the dose that you deliver. I now call upon Dr. Sharanya from radiation oncology to discuss further.
So as we know, ionizing radiation is the radiation delivery can either be proton or photon, and photon is most often used worldwide. We can deliver radiation by natural fractionation, usually a lower fractionation 1.2 to beta fraction. figure, we can see that this plan is a very poor plan. The conformity index is only 0.5. We can see that the I0 line is not at all conform to the target. Whereas in the fifth plan, we can see that the I0 line is well fitting within the target volume, having a proposed index of 1, which makes it a perfect. The next parameter that can be evaluated is gradient index. It is the difference of equivalent radius of prescription I0s and equivalent radius of 50% I0. So here we have the target volume, and here we have the I0s lying at 50% of the prescription. So the difference in the radius between these two should ideally be less than 3, and in our case, the gradient index is 2.6. When we are converted into volumetric parameters, we have our 50%, but then it's nothing but the volume that has been encompassed by 50% isomers volume on the PGV volume. The ideal value should be less than 4.6, and in our case, the volume encompassed by 50% isomers value was 70.848 cc, the PGV volume was 10.97 cc, and our 50% was 1.62. The other parameter is the 2 centimeter, which is a maximum dose in percentage of the static dose. 2 centimeter beyond the PGV in any direction.
deliver if you do the same prescription refraction-based method like refractionation, you can easily control the dose. For example, you can deliver 8.3 to 50% extra dose in a single fraction. The same time, you see 1.6 grade to the 10% extra dose. So that's the beauty of the fractionation. So coming to the therapeutic ratio, so if it's a radiosensitive tumors, the tumor control can be done with lower doses. At the same time, control the tissue damage. But when you take a case of brain where you have radio-resistant tumors, you can't do a tumor control without delivering some damage to the tissue. So you have to be very careful. So what you require is the complication-free cure. So in this case, you have to escalate the dose such a way that you can control the dose, control the tumor, at the same time minimize the tissue damage. So if you see the different dose rates of different equipments, gamma knife for 3.5 gram unit, and for a ZAP it has 1005 mu per minute. So one mu for Linux is equal to 100 centigrade. It means that ZAP can deliver like 15 gray and 7 can deliver 8 gray per minute. So if you see the dose rate effects also has an effect on the outcome. So lower dose rate this is a lower biological effective dose. You see the extreme left curve where the cancer cells for cobalt 60 exposure, the dose rate when it's 0.36 gray rad per minute, the cell killing is poor. When we increase the dose rate 1001 to 107 rad per minute, the cell killing is better. So, and from coming to the radiology basis of SRS, it is different. So, a fraction of more than 10 gray. Including the radiotherapy dose per fraction, it's not applicable for this case because we are in indirect cell death. So LP model doesn't value here. You see the curve here, it is routine survival curve has a red and blue black line, which corresponds to hypoxic cell, oxic cells. But if you see the indirect cell death, it has a different curve. So that's a difference. So coming to the lightning software which we use, it is the latest lightning software which performs planning within a minute. So no need to put your effort and spend your time for planning. So it's called intuitive planning. In this, it has real-time interactive inverse planning approach in which shots and weights are being pre-decided to minimize the beam on time. So it basically has a dictionary composed of individual dose and description of all possible shots and considering all the possible location, size, and shape through which there is intuitive planning. So the new thing, a new improvements in this new lighting software, when we have plan objectives, dose constraints through which we can control the critical organ dose. Also, we have tools to reevaluate the plan, especially in the case of mass-based treatment. So coming to the cleaning, commissioning of CVCT coordinates, there are specific commissioning tools to be done, and this is done during installation and commissioning. So we have also done a study to compare the accuracy of frame-based coordinates with the CVCT coordinates and found that the deviation not more than 5. And also we have essential QAs to be done on daily basis, weekly basis, and monthly basis, which is essential to have a better delivery accuracy of the mass-based treatment. So I'll call upon next Dr. Shiva to continue this. Thank you.
Although the ICON model B with its ability of mass-based image fixation, this was introduced about 2 years ago, and we have only about 1 year of follow-up for this patient. Whereas in literature, it says that 3 to 10 year follow-up is where you see the maximum efficacy of that. But even in this period of 1.5 years, we have achieved significant results. Let me take you through the hormone graph of this patient. To start with, initially he had growth hormone of 80, which after TNTS, there was a 90% decrease in the volume, which made it to 7.64. And post GKRS, we were able to achieve more than half the reduction, that is 3.29 in a period of 1.5 years. The same thing with IGF-1 levels from 1026 to post-op 635 and 593 to 480, which is right now. But this is the most significant result. The patient went from being almost completely blind to near perfect vision. This is stomosoma sadgavaya. Stomosoma leukoplakia. Sorry. The patient's visual field in July 22, you'll see he had bitemporal hemianopia, complete field cuts on the temporal side. Post-op, the vision had improved, and this was a test which was done last month where he has near perfect visual fields with 6/9 on both sides. This shows the post-GKRS MRI at 1.8 year follow-up. This is a cut section which shows a comparison between the pre-gamma knife MRI and the post-gamma knife MRI. Here, this black spot on the top image, this is filled with tumor. This has completely disappeared within a period of 1.5 years. And we expect it to further decrease in size. You can compare all three sections. And the residual tumor volume at 1.8 year follow-up is 7.8 cc. I call upon Dr. Prakash, Senior Resident from the Department of Neurosurgery, to take us through the literature.
Thank you. I'll conclude as quickly as possible. So we are going to do a brief literature review. So giant pituitary adenomas constitute around 6 to 10% of all cases, and they are defined as more than 4 centimeters in size, 10 cc volume, or multi-compartment involvement with less than 6 millimeters distance from the foramen. The Boyle classification and NOS classification are used for surgical decision making. Over the period of the last decade or so, there has been a significant improvement in the outcomes of pituitary surgery. In 2010, our series from our hospital showed that there was a near total excision rate of 74%, visual improvement of 53%, and a mortality of 4.2%. Whereas in 2020, this had improved to a near total excision rate of around 91%, visual improvement of 71 to 97, and a mortality of less than 1%. However, the literature is sparse to determine the exact rates of remission following endoscopic surgery for the giant. So, coming on to stereotactic radiosurgery, this is where the role of it increases in a giant pituitary adenoma, where we are sometimes unable to provide a complete clearance with surgery. So, there have been meta-analysis which showed that almost 1,500 patients across 20 studies showed that there's an endocrine remission and control rate of 43 and 55% at 5 years, which increased to 56 and 69% at 10 years. And the 10-year estimated local control rate was 92%. The visual toxicity was 2.7%, and the rate of hypopituitarism was 26.8%. But the most significant outcome from here was that every 1 gray increase in the margin prescription dose beyond 17 grays was estimated to result in an increased risk of visual toxicity. So that the concept behind fractionation of gamma knife is to reduce the visual toxicity and have the ability to irradiate a larger volume. And recent studies have shown that in both functional and non-functional tumors, there is a good tumor control rate and a tumor reduction size of almost 70 to 75% by using fractionation. So our journey through gamma knife here, for fractionation, we initially started with the extend system, in which we treated a prolactinoma patient. These are the images of that. The extend system, however, had its drawbacks and it required multiple sessions of CT scans to be done, as well as a mouthpiece which had to be fixed on the patient, which was extremely uncomfortable, and therefore it fell out of favor. We then progressed to a staged dosing of the gamma knife with 6 months dosing of 12 days, which also produced good results, but not to the point where we were happy with that. And of late, we have been doing low-dose protocol for the tumors that are present close to the optic apparatus. We give, instead of 24 days, we give 18 days. So the census over the period of the last, since 97 to 2024, we've had a steady increase in the number of pituitary adenoma cases, which we are doing SRS every year. Out of a total of almost 9,000 cases, we have done around 1,298 cases of pituitary adenoma, 247 of which were acromegaly, and 74 mask-based cases were done, out of which 17 were of pituitary. So, proposed protocol for acromegaly, once you have made diagnosis of pituitary adenoma, a baseline MRI, GH, and IGF reports show that it's raised. We then plan the patient for a surgery which can be a transnasal or a craniotomy, depending on the morphology of the tumor. And a 3-month assessment is done post-operatively to assess both the MRI residual as well as the hormone status. In case of a no significant MRI residual and a hormone remission, the patient is kept on follow-up. However, if there is an operable significant remnant present, then the patient is taken up for radiosurgery if it is feasible. And if the patient is affordable, while waiting for the radiosurgery, he can be started on the medical management. If if it's an inoperable residue that is present or if the hormones are reached, then the patient can be planned for GKRS, which if it meets the criteria of being less than 10 cc in volume and more than 3 millimeter from the optical capital, then it can be a single stage GKRS of 18 to 24 days. And if it doesn't meet the same, then it can be a staged fractionated GKRS with a mass of 8 into 3 fractions or 5 into 5 fractions. I'd like to thank all the people who are involved in the presentation and organization. I would now like to call upon our Radiosurgery head of the department.
So the times have changed. I mean, I remember since 1996 when gamma knife first started to now, when we understand more about the biology, how it takes effect. We have facility to fractionate, which we didn't have in the first module B. We are more sure about the tolerance of all these critical areas. Earlier, we were not sure, and we used to. The whole world was very sure. The whole technology was not very. Now we are more sure about how much dose of radiation can optic nerve tolerate, can the brainstem tolerate. And finally, the gamma plan has improved tremendously. It's like the AI of gamma knife. You don't have to do anything. You just put the image in, press a button, and then watch. Everything is done by the computer now. I remember earlier we had to place each shot. It's like you have a can of different size balls. You have a shape of the tumor, and you have to fit those balls in it and cover as much area of that. So you place one shot, so the whole thing changes like this. Then you put another shot here, then it shrinks. So we really have to work hard. But all that is done by the computer now. You don't have to do anything, which is fantastic because humans make terrible errors, and some errors have been made in those complications list. While I think the computer does not make much errors, it makes a very beautiful plan. Thank you.